if there is a risk, it is so small that it is hard to apply to an individual. The risk of getting in a car and driving and having a car accident is probably higher than the risk conferred of taking hormone therapy.
Professor Davis, I'm so delighted to have you on the show. I received the press release on your research and I was instantly captivated because you're really talking about a topic that doesn't get as much airtime. We talk a lot about hormone replacement therapy, which I believe is now called menopause hormone replacement therapy. But testosterone is either regarded as the panacea for everything or the devil. So I'm curious about your research because you have read every single paper and research on the topic and you are truly the expert.
Well, thank you. Testosterone is a normal female hormone, but I always talk about the Goldilocks theory. You don't want too much and you don't want too little. You want it to be just right. And that's probably important for women.
We don't understand, I guess, all our lives we've been told we have estrogen, the boys have testosterone, but that's not the case at all, is it?
Men have estrogen and testosterone. They just have more testosterone. Women have both hormones as well. And overall, they have more estrogen. And that's what makes us female. And our chromosomes are what make us more female. So the ovaries make testosterone, as do the adrenal glands. The adrenal glands make testosterone right throughout life. The ovaries stop making a significant amount of testosterone once women get to menopause. But there's still plenty of testosterone around for most women. You need testosterone to make estrogen. Estrogen is made from testosterone. So it's a really important building block hormone.
There's a time where, just like our estrogen drops due to menopause, there's a time in our life where our testosterone production drops as well. Is that correct? But they're not linked.
So there's no acute change in testosterone at menopause as evidenced by the research we have to date. We are doing further studies to look at that presently, but right now the available information is that there's no acute change in testosterone at natural menopause. Testosterone starts to fall from about the age of 18 through to about the age of approximately 45 years. It doesn't vary much after that. So by the time women are in their 40s, they have about 75% of the testosterone they had when they were younger. So there's about a 25% decline. But what our research has also shown, which was unexpected, is that from the age of about 70, testosterone levels start to rise again. And by the time women are in their mid-70s, their testosterone levels are the same as when they were in their 20s and 30s.
Wow.
So there seems to be some survival benefit of older women having healthy, shall I say, healthy levels of testosterone.
Professor Davis, explain to me again the role of testosterone in a woman.
So testosterone produced by the ovaries and the adrenals gets released into the bloodstream. It can go to cells and act as testosterone. So we call that an androgenic effect. Or within cells in the body, like bone, fat, the brain, all over the body, it can be converted into estrogen and then act as a supplier of those tissues of estrogen. So it has two important effects. The other thing is that it does have favorable effects in the blood. So we know that testosterone has effects in the brain. It has effects on blood vessels. It causes blood vessels to dilate. And it does have favorable effects on tissues like muscle or skin. So if you have too much testosterone, you get all this skin and acne. But a healthy level testosterone gives you, I guess, normal skin, not dry, withered skin. So testosterone is important.
I saw in one of the articles that you've published that it's really difficult to measure testosterone in the system, and that inability to accurately measure our levels of testosterone then limits what our physician can prescribe for us, or understanding how much we need to top up and when we need to top up. What does that all mean, and how should we be getting our testosterone tested?
Okay. So firstly, no one should be getting their testosterone tested unless they're on testosterone therapy. There is no lower limit of testosterone that is associated with disease. So even when we have measured blood testosterone by the most precise measures that enable us to get the lowest levels in women, we have not been able to show meaningful associations between testosterone and any clinical symptoms. So testosterone is not associated with clinical symptoms in otherwise young, healthy women. Okay? So don't get your testosterone measured to make a diagnosis of anything. That's the first thing. The other thing is the limitations, if you've asked. Most laboratories measure testosterone in women using the same instrument they use to measure testosterone in men. So in men, the range of testosterone is, say, 10 to 30 nanomoles per litre. In women, it's approximately anything up to about 2 nanomoles per litre, depending on the instrument you're using. Well, approximately, using those techniques, standard techniques. So that measurement can tell whether a man's different between, say, is 10 different to 15 in a man? Yeah, absolutely. 10 is different to 15. It can't tell if 1.5 is different to 1.6 in a woman, or even if 1 is different to 2 in a woman. The instrument's too blunt. It's like using a ruler to measure millimeters and try and say, oh, I'm using this ruler and this pinhead is 1.5 millimeters, not 1 millimeter. You wouldn't believe the result, would you?
No.
Because it's too inaccurate. It's too blunt an instrument. So that's with the standard labs if you're sent off for a blood test. The research we do, we use highly precise, what's called liquid chromatography, mass spectrometry. People don't really need to understand all of that, but we can measure really low levels of testosterone with great accuracy. So that's when we can do research to say, in several thousand women, is testosterone in the blood associated with a particular outcome with accuracy? But most of the studies published have never measured testosterone with accuracy and are completely unreliable and uninformative.
So when you go and get your bloods done before you're prescribed your HRT and there is a reading on testosterone, are you saying that that should largely be ignored because it's been measured incorrectly?
It should be totally ignored, not largely, completely ignored.
One of the other things that I read
Can I just say, why would anybody get their bloods measured to go on HRT anyway? Unless all the international guidelines state very clearly, unless you're under the age of 45 or you are not bleeding when you think you might be going to menopause, like you've had a hysterectomy or an endometrial ablation, or you have a hormone IUD, or you're on the pill. Well, on the pill, you shouldn't have your blood measured. There are only certain indications where you would ever have your blood measured before having HRT or MHT, whatever anyone wants to call it. There is no value in most women over 45 having blood levels measured of anything to diagnose menopause.
Okay, so there's two schools of thoughts with regards to menopause hormonal therapy. There's the compounded prescription, which might be a combination of testosterone, progesterone, and estrogen. And then there's the pharmaceutical version, which is often an estradiol, is that correct? And then you would then top it up with a testosterone cream or progesterone cream additionally. But I read that you think that the compound...
None of that is correct.
Okay, tell me what is correct.
What is correct is this. Let's keep it really simple to begin with. If a woman has had a hysterectomy, with or without removal of her ovaries, the only hormone therapy she should use, if she has symptoms, there is no evidence of benefit other than bone protection for women without symptoms. That is it. The only treatment to be used is estrogen. Whether you get it from these naughty pharmaceutical companies who in fact are highly reliable, it is bioidentical as estradiol. Whether you get it compounded, which is not approved by any regulatory government organisation anywhere in the world, there is no guarantee that the dose you are using is appropriate to alleviate symptoms, or that it is absorbed, or that you're not going to get really high levels that are unsafe. And I have seen women on compounded hormone therapy with frighteningly high levels who were given no product information, who have even had breast cancer. So there's nothing particularly safe or special or good or nice about compounded therapy. In fact, it is unregulated, unproven, and mostly inappropriate. In Australia, compound therapy should not be prescribed unless there is clear evidence that there is no equivalent TGA-approved product, or that a woman is clearly allergic to everything else. If a woman has not had a hysterectomy, she has estrogen with a progestogen. There's a whole range of progestogens, and a progestogen is a compound that protects the lining of the uterus and causes progestational effects in the uterus. Now, there's a big trend for everybody to have progesterone. There are several things. For many women, progesterone does cause side effects. I'm talking progesterone versus the synthetic analogs. Progesterone can cause side effects like fluid retention or excessive sleepiness, which some people can't cope with. In some women, progesterone is not sufficient to protect the lining of the uterus. And for women with very high-dose estrogen needs, there's no evidence that progesterone will be sufficient. And finally, everybody is peddling the idea that progesterone does not cause breast cancer when given with estrogen, 17-beta estradiol. We don't know. There is not a single placebo-controlled randomized trial of more than 12 months duration that has shown that progesterone is more or less safe on the breast. The observational data from the 3N in Europe suggests that progesterone with estrogen use up to 3 years did not increase risk of breast cancer, but after 3 years there appeared to be a small but statistically significant increase in breast cancer risk. It's not a randomized controlled trial, so we don't know. And it is wrong for anyone to be of the belief that if they take estrogen or progesterone, whether it be pharmaceutical or compounded, that that's safe. And
Well,
finally,
yes, go ahead. Go ahead.
And finally, the only indication for testosterone in women is for the treatment of low libido that causes distress. There is no evidence that it will improve well-being, mood, fatigue, headaches, hot flushes, cognitive function, you name it.
You've raised the big fear that everyone had that kept them away from hormone replacement therapy for about 20 years, the fear of breast cancer. So where are we at? Because there is just two very split schools of thought. As you said earlier, there's a huge push to hose down any discussion about breast cancer. There's almost a tidal wave of doctors and specialists coming forward saying, forget everything you've heard about hormone replacement therapy being linked with cancer. That was an incorrect study that was taken out of context. Where we're at now is that it's perfectly safe, and in fact, it could even support and be helpful for breast cancer prevention and sufferers.
There is no quality evidence that hormone replacement therapy prevents breast cancer or is safe for women who have had breast cancer.
What is safe menopause hormone therapy that is evidence-backed? Where are we at? Like, what should we be getting? And if we're getting prescribed a compounded formula, or if we're not, or if we're being told that we need testosterone somewhere in the mix, how can we advocate for ourselves with knowledge?
Okay, so the Women's Health Initiative study used a particular estrogen formulation. That formulation was not associated with an increased risk of breast cancer during the trials or in the follow-up. Does that apply to every product available? We don't know. So can we interpret that particular formulation, which was pregnant mare's urine-derived hormone therapy, applies to an estrogen patch, compounded gel, or other estrogen therapies? We don't have the data. And I think people should be informed. It appears that estrogen only is probably safe. Okay, probably. But certainly that particular formulation did not show an increased risk. Then the combination of the oral estrogen tablet, pregnant mare's urine-derived, and medroxyprogesterone acetate was associated with a small increased risk of breast cancer. Does that apply or not apply to any other formulation, pharmaceutical or compounded? We don't know. But what is important to drill down, and I think there are two really big takeaway messages. If there is a risk, it is so small that it is hard to apply to an individual. And it's understanding risk. The risk of getting in a car and driving and having a car accident is probably higher than the risk conferred of taking hormone therapy. We take risks every day. If you don't drive a car, that doesn't apply to me, I don't drive a car. Okay, crossing the road. Going out your front door. Most people will cross a road at some point in their life. That the risk is so small. And I think one of the greatest philosophies I heard about this is, if the risk was screaming at us, we wouldn't be arguing about it for 20 years. We've been arguing about this risk for 20 years. No one argues about the risk of smoking and lung cancer. No one argues about the risk of smoking and heart disease. It's so clear. So if there is a significant risk, it is so small that women who use HRT are taking those risks every day in their life. Drinking alcohol is probably associated with a greater risk, but not all, but many women do that. So my approach is that women can suffer their symptoms for 20 years if they want and not take menopausal hormone therapy because they're so scared to take it.
Which has been the case for 20 years.
And still get breast cancer. So women get breast cancer, and if there is a significant variation in risk with hormone therapy, it is so small that probably both sides are a bit right. And I said at the beginning, the truth lies in the middle. And finally, in the Women's Health Initiative study, after 18 years of follow-up of women who participated in their study, whether they took active or placebo, whether they went on to take HRT later or they didn't, the likelihood of dying from breast cancer was not different between the two groups in either arm of the study.
You made fun of people's aversion to pharmaceutical prescriptions when it comes to menopause hormonal therapy. And you've made, probably for the first time that I've spoken to anyone, a distinction between the unregulated aspect of compounded formulations versus TGA-approved medicine for menopause hormone therapy. Why do you think that this, not diversion, but I guess these two parallel thoughts have been almost fighting at each other when the goal should be to protect women and to help make the menopausal rite of passage as comfortable as possible?
The TGA, which is Therapeutic Goods Administration, which regulate all products in the country, including over-the-counter sold in pharmacies, they're regulated. The TGA does not have in its mandate to oversee or regulate any compounded therapies. So compounded therapies are completely unregulated. That's number one. Number two, when a woman gets compounded progesterone, a patient of mine recently, she has compounded progesterone in capsule. I see no justification why that should be prescribed when there's TGA-regulated capsules of micronized progesterone, which have to go through purity certification, proof that every capsule contains the same dose. They're all made up under control conditions. And they cannot be marketed in a way that has any confusion. And every packet of medication comes with an insert into the risks and benefits and safety and who should and shouldn't take it. Compounded stuff is just the same stuff that's mixed up in the back of a pharmacy with no regulation, and patients get no product insert, no warnings about these could be possible side effects, or these could be benefits, or what interactions there might be with other drugs. And there's no regulation on pricing. So women are taking a whole lot of compounded stuff that may not even be absorbed. If you get progesterone in a cream, there's no proof that that cream will actually go beneath your skin. So I've had patients taking estrogen using a progesterone cream. I measure their blood progesterone level and it's negligible, which means they're basically taking estrogen without the protection of anything. I've seen patients on testosterone with blood levels like men. I've seen patients on estrogen compounded with blood levels like a pregnant woman. So I've seen everything, and it's unregulated, and there's no justification. And there's this naive belief that it must be better for you. There's no evidence. It's the same stuff that TGA is regulating. And the people who are making it are making money. And that's why I joke about the nasty pharmaceutical companies. Everybody's making money. No one's doing this because they really want to not make money and just do good things for women. We have to be wise consumers. We have to, if you're given a prescription therapy, or if patient X is given a prescription therapy, they're going to ask me about what's the safety, what's the evidence, what are the side effects. They're given compounded. For some reason, it's got this magical aura of safety and natural about it. It's not natural. That's my rant.
No, it's great insight because we've never really talked about it. Can you tell me, going back to the testosterone, because you've done a lot of research on testosterone, there are benefits though in your research. You've seen some impacts of adding testosterone therapy for heart health, for brain health, for muscle recovery. But you're saying that it's not something that you should automatically whack onto your menopause hormone therapy.
So I've got to be very careful. Our research is on our clinical trials on testosterone are what's called mechanistic. We have data on thousands of women, postmenopausal women, showing that testosterone will improve in about 60% of women sexual desire and sexual function in postmenopausal women with low desire. That's a clear finding. We have shown in studies of cognitive function that there may be a very small benefit in terms of verbal performance. So women performed 1.5 words better with testosterone therapy, okay? And that's a study of 50 women with active and 50 women with placebo. There's no other equivalent study, so before running out saying it improves cognitive function, we need more data. We have not studied muscle, but the available data, or we've studied muscle, but the available data on muscle is very conflicting. I think the largest study is 20 women in each group. Again, that's not enough to go shouting from the rooftops, every woman should take testosterone, it's improving their muscle. Currently, we're doing a randomized placebo-controlled trial of testosterone to measure muscle function and performance and bone density in postmenopausal women. And it's a large study. And if any women in Melbourne are interested in participating, they can come to our website and offer to join the study. But we need the data, so we can't say that. And we're looking at bone too. And mood and well-being, the data on large numbers of women do not show improvement on mood and well-being compared with placebo. Our studies and other people's studies. So if people want to cherry pick the literature, they can find whatever they want. But if you look at the quality research, the data's not there. So the hardest part about doing studies in any of this area is the placebo effect.
It is my favorite aspect of any research that I read. It always blows me away, that placebo effect. And one of the reasons that I launched the podcast was to have these conversations with real experts, because women, men, people, we all get together, we get our information from so many different unauthorized sources. And as you said, the human brain tends to cherry pick what they want to remember, what they want to believe. And your research, you're talking about real numbers, and you're quite right. A cohort of 20 people studied is
It's
not
nothing.
something that is worth shouting about, and it may not apply. You don't know what the ethnicity of that cohort is, the health of that cohort. So for me, the gift of having someone like you on the show to talk to ordinary people who are so confused or getting their information from a limited source and really can't advocate for ourselves even when we're sitting with our health professional. So in
True.
full disclosure, I've only ever had compounded hormone replacement therapy. And now my brain is exploding, but now I have words. I have questions that I can advocate for myself, to ask better questions. And so, you know, it's frustrating and it's difficult. It's way more difficult than watching something on TikTok, like, Davina, what was her name? The lady
Being
who,
Nicole.
yes, Davina McCall, who
And
popularized
suddenly this
testosterone.
woman knows more about menopause than someone who's been working in the area for 20 years. And, so why should anyone believe me? Would be a fair question. Because I've got no agenda. Because I'm a female. Because I actually still take HRT and I'm happy to talk about it. I want to know what's safe. I care about what's safe. I'm not in it to make money. I'm not in it to have a profile on TikTok or YouTube, or I don't want to go on YouTube and talk to a whole lot of people and make money from advertisements. I don't sell anything. I'm not interested. I'm interested in finding the truth. And that's why we're doing it. We've just recruited 7,500 women across Australia, aged 40 to 69, to
That's a
find the
study.
truth. To
That's a
find the
study.
truth. And we have asked them everything, and we've got blood samples, and we're going to try and go back. So when I said testosterone doesn't change at menopause, that's based on what we know. But this study is going to really tell us, does it change at menopause, because we've collected blood. So I think you've got to be really careful. And I think the compounded stuff's been a hard sell of people who sound like good do-gooders, who may be evangelists, but there's no evidence. There's no evidence for safety. You're not given any warnings about who should and shouldn't take it.
So just
And
to absolutely clarify,
yeah,
forget about any testosterone therapy. We don't need it. Forget about unnecessary blood works. We don't need it. And what we really do need is estrogen and some progesterone at the same time to protect the lining of our uterus. Is that correct?
yeah,
And if
correct.
we've had a hysterectomy, we don't need the progesterone. We just need the estrogen. Next part of the question is, what happens if you were part of the cohort of women who were terrified by the prospect of breast cancer and never had hormone replacement therapy, never. And now you're in your late 50s, 60s, 70s, and osteoporosis, other heart disease, dementia, other things that are supposedly linked with not having correct hormone balance are top of mind, because for 20 years there wasn't this plethora of information, and now there is. Is it too late to start any kind of menopause hormone therapy?
Okay, so it's difficult because I think we're just actually reviewing the literature on this and preparing an article on this, and so it's a timely question. The evidence from the Women's Health Initiative study, so let's just stick at that first, was that for women aged less than 60 years or within 10 years of menopause, it appears to be completely safe to just start hormone therapy at any time within that time frame. Having said that, it's very confusing to interpret. So if someone went through menopause at 45 and they're now 59, they're more than 10 years post-menopause. How do you apply that information? We don't know. So, but then if you dig down into Women's Health Initiative and you look at women aged between 60 and 70, the evidence would be such that it probably is perfectly safe to start a low dose of hormone therapy if you need it. So then you go back and ask the question, why would anybody, say more than 5 years post-menopause, consider taking hormone therapy? And there are two indications that are clear, that are agreed by all the international guidelines, and we've just published these summary of international guidelines a couple of weeks ago. One is symptoms, and I'm talking about hot flushes, night sweats, and low mood. They're the main symptoms. And in general, I am happy to prescribe low dose, non-tablet form, so patch or gel, estrogen to a postmenopausal woman who's more than 5 years postmenopause with symptoms that really trouble her. And the reason I use a patch or a gel is because we know that they do not, at a standard or low dose, do not increase the risk of thrombosis, and will probably protect bone. You don't need a lot of estrogen to protect bone. The other reason I would use it, as you raised the thought, is for bone protection. And again, I'm happy to use low dose, non-oral estrogen with or without progestin for bone protection. And the other thing I quite often prescribe is a synthetic type HRT called Tibolone, which at low dose protects bone and does not increase the risk of breast cancer. But every woman has to be assessed regarding her own profile. Does she have blood hypertension? Is it well controlled? I'm not going to treat somebody with raging hypertension with estrogen. So has she had a mammogram? Is there a high risk of breast cancer? So if we take the pristine 63-year-old woman who's still getting hot flushes and night sweats, her bone density is a bit down, she has no other health issues, she's normal body weight, or might be slightly overweight, no other health issues, yes, I would give her estrogen and progesterone. But if somebody has major health issues that would give me great concern, I'd have to weigh up risks and benefits.
And Professor Davis, how long, because earlier on I thought I caught you say that it's not safe to be on estrogen indefinitely.
No, you misinterpreted me. No, there's
Okay.
the 18-year, no, all the guidelines say for as long as there's an indication. But can I say there's the evidence that HRT will make you live longer or prevent dementia or prevent heart disease is still unestablished. It's not clear. So the main absolute indications that everybody agrees on are hot flushes and night sweats and low mood associated with menopause, but not severe depression, low mood or mood changes.
And you've done some research around sexual function and menopause. So you're saying that testosterone may or may not help with that. Estrogen that's not the primary indication for estrogen therapy. What in your experience and what in your research will help with that aspect of menopausal symptoms?
Testosterone will help about 60 to 70% of women with low libido. It will help. Is it going to make you feel like you were 16 or 18 or 20 or first married? No. But it will help women with low libido. And for some women, it makes a tremendous difference. The problem is there's no predictor. So if you was to talk to me and say, look, I'm in a great relationship. This is the classic story. I feel like a light went out. I used to be interested in sex. I used to be responsive. I just feel it's all switched off. And then there are no other major, things. I would be prepared to prescribe testosterone. I can't predict. There's no blood test that's going to tell me, are you going to be a responder? But the responders get a good response. And women are either responders or non-responders, and about 60 to 70% are responders. Even if they're on antidepressant therapy, they're often women who are responders. So that is an indication for testosterone indeed.
And may I ask you, what are your thoughts on vaginal estrogen preparations in addition to menopause hormone therapy, estrogen patches, or pills or compound, in whatever the case may
Whatever,
be.
yeah. So when estrogen levels drop, the vagina tissue becomes thin, friable, dry. Women often experience urinary frequency or sort of that urge to rush to the toilet, or getting up at night to go to the toilet. And those symptoms will respond generally very well to local vaginal estrogen that can be used as a vaginal little tablet or as a cream, and probably to be approved in Australia, vaginal DHEA, which is like a compound that gets converted into estrogen. It's effective, it's cheap, it's safe, and there's no reason most women should not use it. Most women probably should use it. Our research says that only about 6% of women who are postmenopausal are using it, but over 50% of women have symptoms, so it should be more commonly prescribed.
And is it safe to use in conjunction with your menopause hormone therapy? And is it safe to use indefinitely?
It is safe to use with hormone therapy. It is safe to use without hormone therapy, and it's safe to use until you're in the grave. So women can use it for their entire life. And it, in one study published years ago, like 30, 40 years ago, showed that using vaginal estrogen protected women from urinary tract infections. So it is good for every woman, even if they're not sexually active.
And do you need the progesterone preparation in conjunction with taking vaginal estrogen?
Of the vaginal estrogen products available in Australia, progesterone is not required. So it's just vaginal estrogen twice a week will make a huge difference to many women and should be prescribed more often. And often is needed even if women are on a patch, a tablet, a gel, or whatever they're using.
Right. Well, I feel like we've covered so many things. Is there anything that you would like to add from the research findings that you're publishing and you're finding now that you want to do some myth busting? Because I feel like this episode has been absolutely profound in your ability to take, things that have been swirling around in the atmosphere and like land them with some concrete scientific evidence.
Look, I think that it's really important to look at information and look at the source of the information, who's writing it and why they're writing it. And when people have a terrible experience, say with menopause or after some major life experience, they're often compelled to write their story. But their story is not necessarily your story. And I think you have to be, if someone's advocating for a particular thing, understand why they're advocating for that. And it may not be right for you. And try and find the evidence, like things like the Jean Hales Foundation, the Australasian Menopause Foundation, the International Menopause Society. There's so much information available from these organizations, open access to the community, not to women, to people. And ask questions from your healthcare providers.
And you mentioned before that if anyone is interested in participating in your studies, they can do that. Could you just share with us where we can reach you to be considered for participation in your studies?
So our studies are in Melbourne and we've got one in Perth, and there are different studies we're doing. So the best thing would be to go to the Women's Health Research Program at Monash, and there's join the study page. So Women's Health Research Program, Monash University.
Fantastic. Professor Davis, this was a light bulb moment podcast for me. I didn't know where it was going to go, and it didn't go where I was expecting it to go, but it was an absolute joy and pleasure to meet you. Thank you for the straight talk. Pleasure. I appreciate it. And I'm sure that our listeners and viewers will really appreciate learning from your extensive expertise in the subject. Thank you so much.
Okay, cheers.